So welcome everyone to our First Friday webinar. We started this webinar to allow educational space for both medical and legal community and personal injury to learn more about neurotrauma care. We've been doing this for the last few months. It's been great to have speakers of all types come on and look at neurotrauma from many different angles. Today is going to be a focus on the mental health aspect. We've got Kristen Noyes here. And before we get started with that, I just want to introduce you to All Things Neuro so you can be familiar with what we do. So All Things Neuro is an umbrella company where we have several different types of companies all under one umbrella. The goal is to be a comprehensive solution on neurotrauma care. So we partner up with specialists on all expertise like neurologists, psychologists, neuropsychologists, speech language therapists, functional neurologists, physical therapists, and psychiatrists, just to put it in a nutshell. So our goal is to have continuity of care, making sure our patients are receiving consistent, coordinated, and a comprehensive solution. And one of the reasons that we started was that we noticed that a lot of the patients that came through personal injury were being missed. Statistically, it's over 60% on the TBI side. On the mental health side, less than 10% are seen for their cognitive disorders. And so our goal is to be able to assist, case manage, and make sure that every person who's been injured has the opportunity to receive the care that they deserve. So from the evaluation process to testing to treatments of all sorts. So our goal is to be a one-stop shop. We have diagnostic testing for concussions. We have our psych centers, which is all telehealth, and then concussion rehabilitation. And then on the legal side, we also offer independent medical examinations. There are several of those that we offer, impairment ratings, life care plans, and forensic analysis to support the legal side. Even in the litigation space, we can come to the table. But today, we are going to be focusing on trauma-based therapy, EMDR, and excited that Kristen is going to be illustrating that is one of those newer types of trauma therapies that many people haven't heard of before. So we're excited that she's going to be working with us. Before we start, I do want to give a plug about our conference that's happening at the end of October. I'll be posting this again at the end, but we're really excited to be bringing this to the Southeast. And the goal is to do this every year and for it to be a national event. So this is for both the medical and the legal track to be able to come together and learn more about neurotrauma and how we can work the cases together for better recovery. So with that being said, I'm going to introduce Kristen. Going to do some technical things here. And Kristen's been with our company since the beginning of psych centers. So she has seen our evolution over time. She's our clinical director. She oversees all of our counselors and has been recently certified in EMDR, as well as we have another person, I believe, on our team. And so today, Kristen, if you could go ahead and jump on in.
I will. First of all, can you see my screen, and can you see me, Jen? She's going to be helping troubleshoot with me today. Okay, so you can hear me and see me. Welcome, everyone. Happy Friday, as Jen said, and thank you for introducing me, Jen. My name is Kristen Noyes. I'm with Psych Centers of Georgia, and I'm really excited to be talking to you about an evidence-based treatment modality, which is EMDR, and its advantage in treating trauma. So we're going to be talking about trauma today, and specifically EMDR, which is a therapy modality. And I'm going to talk a little bit about other evidence-based modalities that we use, but we won't spend as much time on that. I know it's odd to be smiling while I'm talking about trauma, but I do get excited about this because of the fact that there are so many treatment modalities out there that are the gold standard for treating trauma. And as we know, the clients that we serve have definitely been through trauma in the personal injury realm. So we're going to talk a little bit more about that. What led me to getting into EMDR is, as a therapist, I was doing what we call bottom down work, which is really getting into the cognitive part of trauma and our symptoms. And it's very effective, and I still use that as well. However, I was finding that at times I could only get so far with my clients. Symptoms would be managed, they would be better, people would be functioning better, but sometimes there was still a little bit that was stuck. So I was looking for different modalities, and I began hearing about EMDR. And as Jen mentioned, it's relatively new, and we'll talk about that a little bit more, but I'm going to go ahead and jump into trauma now. So as we know, physical injuries are much easier to identify than trauma. Trauma is the injury behind the injury. So we're going to talk a little bit about what big T and little t is. We're going to talk about our nervous system and how trauma shows up there. And we're going to talk about symptoms that are relevant to trauma, things to be looking out for in your clients. Now, I'm hoping we're all human beings here. I know we have a lot of chat bots and bots that are coming, but if you are human, you have most likely experienced some sort of a trauma. And so I want to talk a little bit about that, because when we think about trauma, generally, we think about the big traumas. So big T's, what we call it in the therapy world, big T's being the ones that are more evident, that are in your face traumas, such as assault, violence. You can see the top bullet here is life-threatening accident. So that checks the box immediately for the majority of the people that we work with. We're going about our day and there's a sudden impact to your life. You're not aware that this is about to happen. And before you know it, your life is turned upside down. Natural disasters, war and combat. These are the big T's, the things that we can see and we're aware of. Now, little t, which is more nuanced, these are going to be ongoing stressors, chronic trauma, repeated criticism. If you grow up in a household where you're constantly criticized, even mild neglect, you're not getting your needs met often, even if your caretakers are there, this can build up over time and create a trauma response. Medical procedures, this is really relevant to our cases as well. Just by merely going to some of these recommended medical procedures to help heal their injuries, they're almost being re-traumatized, because every time they go, even sometimes every time they get a call to schedule, it's a reminder of the accidents. But also just the medical procedures themselves can be traumatizing. They're already in pain, and often the procedures that they're participating in are exacerbating or aggravating that existing pain. So it's very difficult for people to continue to repeatedly expose themselves to discomfort. And losses and disruptions, sometimes I feel like, even though that should be a more obvious one, we often grieve in isolation, which can create trauma. There's even complicated bereavement, which is a diagnosis as well. So there's a lot of nuance to trauma. The most important part about trauma is that it's subjective. So no two people experience trauma the same way. We can have two people have a motor vehicle accident, and one person may recover faster, where they're able to discuss what happened without becoming activated. That's how they've healed. That's showing that they've healed and they're functioning well, where others get stuck and they're repeatedly experiencing the trauma, which is post-traumatic stress disorder. I'm going to talk about that a little bit more too. So before we get into these common responses, I'm actually just going to stick with PTSD, because it is a diagnosis, post-traumatic stress disorder. Post being after the trauma, it lingers. It requires, the diagnosis comes with a requirement that these symptoms have been existing for at least 6 months. My belief is that this diagnosis, even though it's a diagnosis and it's a compilation of symptoms, it is stuck trauma. It is trauma that has not been processed out. It is trauma that is stuck in our body. It is reoccurring memories of the trauma and living it as if it's still occurring. This is where EMDR comes into play, and we'll talk about that a little bit more. But imagine, well, this is me showing my age. So I was going to say, imagine a record player, being stuck in a loop and it can't move forward. Essentially, that's trauma, being stuck in a loop. I could move on to CDs, but that also is showing my age. So, but basically, PTSD is getting stuck in a loop. So fight, flight, freeze, and fawn. I'm sure you are familiar with some of these words. This is a common neurological response. It's our body's response to trauma. So we have an automatic nervous system. We have the parasympathetic and we have the sympathetic. The sympathetic nervous system is responsible for our fight, flight, and freeze response. You see fawn on here. I'm not going to talk about that as much because fawn is a learned behavioral response. And I'm going to stick with our biology because EMDR, which is amazing, is that it addresses not only the memory and the cognitive piece of it, but also the body part of it. So fight, flight, or freeze. You have most likely experienced this as well. It is essential for survival. We need to have these responses. Fight is going to be when the response is more that anger, irritability, defending yourself physically, aggression. It comes in handy if you're trying to protect yourself from a violent situation. Flight as well, you know, anxiety, restlessness, avoiding situation. When it's happening, when present danger, that's your ability to flee, to get away from that danger. And freeze is going to be the numbness, the shutting down, the inability actually to act, which can be the most dangerous one to be in. It happens often with children because their physical size, often they cannot fight and might not be able to flee. And so the shutting down and the dissociation is literally their brain protecting themselves from having to experience what's happening in that moment. So while this is relevant and necessary for our survival, this happens when we experience a trauma, specifically a sudden trauma, like our accidents. Where it becomes a symptom that needs to be treated is when we're repeatedly experiencing these symptoms in our body, even though we're not in danger. So we now have an overactive nervous system. This is going to be triggered specifically with post-traumatic stress disorder by the memory, by anything that reminds them of the accident or the trauma. So this can be smell. Even a smell can trigger these responses. Anything that they see driving by a side of the accident. Let's say it was a truck that was involved in your accident. So anytime you see a truck now, you're responding in one of these fight, flight, or freeze. Whatever you experienced during the accident, it's coming back up again in that moment, even though you're technically safe. So this is what we're treating with EMDR. So these are symptoms relevant to all trauma, but specifically PI cases. These are the things that your clients are going to be describing to you or that you're going to see. So many of my clients are talking about the disruption to their sleep. They're experiencing it in their subconscious. They're having nightmares. In their waking hours, they're having flashbacks where they physically feel that they are experiencing the entire event currently in this current present moment. It's a little different from intrusive memories where you're more thinking about it or ruminating it. It comes up multiple times throughout the day or throughout the week, thinking about the trauma. Hypervigilance, I'm not sure that I've worked with a client that's been in a motor vehicle accident that hasn't had hypervigilance or the exaggerated startle response. What's important about understanding these symptoms too is we can give language to our clients about what they're experiencing. And right from the beginning of our work together, they're beginning to understand what's happening to them, give them language to describe it to themselves and to others in between sessions. And it starts to normalize, even though it doesn't feel good, this very real experience. So an exaggerated startle response is going to be you're sitting in a car and something moves in your peripheral vision and you're jumping. You're just really jumping. Hypervigilance is you are on a 10 of your observation at all times. You're looking at the left and the right and the front, the rear view mirror. Your head's on a swivel, basically. You're constantly chronically alert. Other symptoms, this is very important, is avoidance behaviors. So as I mentioned, going to medical and legal appointments is a reminder of what's happened, but also oftentimes leaving their homes becomes difficult because that's their sense of safety. Their sense of safety has been, wrecked. A rug has been pulled out from underneath them. Now they don't believe that anything is safe. Avoidance is pretty critical in our treatment because the more that somebody avoids that which they fear, it actually increases their anxiety. So while I'm talking to my clients, they don't want to hear this. And I say this kind of seems, like it doesn't make much sense because what you want to do is avoid that which created harm. Of course, that's a normal response. However, in avoiding all things and associating all things now with that fear is going to increase your anxiety, increase your avoidance, and can lead to other diagnoses such as panic disorders and agoraphobia, which is not wanting to leave your home. So PTSD, panic disorders, agoraphobia, and anxiety disorders are very common with people who have experienced trauma. Psychoeducation is a huge piece. I'm explaining to them what trauma is before I even begin working with them, because then we have language to start describing what we're experiencing. Concentration and memory difficulties is also a part of trauma. And this can be difficult to tweak out because a lot of our clients have experienced a TBI, right, or a concussion. So they have concentration and memory difficulties. We're going to get into this a little bit more, but in the treatment of these symptoms, once we reduce these things, we can see an improvement in concentration and memory as well. So they have the cognitive benefit in treating trauma. And this last part, I'm sure we've all seen in the work that we do, is irritability, mood swings, maybe emotional numbing. The way that the clients present, it's exhausting being dysregulated chronically. And essentially experiencing trauma, living in trauma, and repeatedly feeling like you're living that over and over is going to lead to this exhaustion and this irritability. Okay, so let's talk about evidence-based trauma treatments. We're here for EMDR, but I still want to just put a little plug in there about the gold standards for trauma treatment. So I'm thrilled to work with a team of highly skilled clinicians. We are all trained in CBT, which is the original gold standard for trauma treatment. Several of us are training in EMDR, and a few of us are certified as well. So CBT stands for cognitive behavioral therapy. What that stands for, or what that means, is that we're doing that, as I mentioned, the top down. We are working on how our cognitions or our thought patterns affect our behaviors and vice versa. It's very effective. However, it doesn't address the bodily symptoms and where trauma gets stuck in our body. CPT is a more specialized, specific type of CBT. It usually takes about 12 sessions. It's a processing and a talk therapy. Prolonged exposure is very helpful with that avoidance piece. Many of our clients are either no longer driving less, driving back roads, avoiding highways, making adjustments to how they drive. They'll only drive at certain times a day. So with exposure therapy, we are gradually introducing them to getting back to that which they fear. So I'm just going to do a quick example. I usually will describe this to my clients as asking them to imagine getting to the top of a roof, like a 2-story building. Keep it low, not a high rise. So how do we get to the top of the building? Usually someone will say, a ladder. Okay, so how do you use the ladder to get to the top? And they kind of look at me. But eventually someone will say, step on the step. So we take a very slow step-by-step approach. The top rung would be their ultimate goal of, say, driving or driving on the highway. This is an individualized approach, depends on the client. But we don't just jump to that top rung. We don't just jump and go. And the reason I explain it this way is no client would even have buy-in to me to just go start driving unless I brought it down to that very first step, where what we're doing is we're helping them identify what would be the least activating or anxiety-inducing step to take to reintroduce driving. And sometimes that is sitting in a car and just turning on the ignition and noticing what they're feeling in their body and practicing some of the skills I'm going to talk to you about. That comes from EMDR. Long story short, we do one step at a time, where, let's say on a scale of 1 to 10, 10 is the worst anxiety, it's panic attack. That would be that top rung for right now. That bottom rung, sitting in the car and turning it on, maybe invokes a 3 or a 4. So we're going to sit there and do that experience over and over until it's down to a 1 or a 2, and then we'll move to the next step. So we build until we get to where they have decided that they want to be. Why evidence-based trauma treatments? Because it's credible in medical and legal settings, and because As therapists, we want to cause no harm and we want to heal. So of course we want to be practicing from where there's research and evidence. And I'll share some case examples with you a little bit later. Also, they're measurable. We can specifically see how this is impacting our clients, so we can stand behind it. Okay, so this brings me to EMDR. Bear with me here because I'm used to interacting with humans more than I am with technology. So I'm going to try to stay focused as I go into EMDR, but I'm going to start with what it even stands for. So EMDR stands for eye movement desensitization reprocessing. It's a mouthful. That's why we call it EMDR. It was developed in the 1980s by Francine Shapiro, 1987 to be specific. So it's really not that new, but as Jen said, it sounds new. In fact, it was new to me. Just to give you some context, I graduated with my master's in social work for the clinical social work in 2008. CBT, as I mentioned, was definitely in there, as well as psychodynamic and Freudian concepts. EMDR was never mentioned. It was developed in the 1980s. It wasn't even a part of my program. So it has really started to become much more mainstream, I would say, in the last 10 years, as more and more people in network, clinicians, began sharing their evidence of how it was helping their clients. So it's becoming much more mainstream. What's great is that it was already and has been recognized by the APA, the American Psychological Association, WHO, the VA, and the Department of Defense. Where it was actually used first and is still used the most, and where a lot of the studies came out of, I'm not going to share those studies today, but is with our veterans to treat post-traumatic stress disorder. This is where it began. And it was so effective at treating PTSD with them that it began gaining traction in the therapy world. Okay, so EMDR is a therapy modality. It is an 8-phase process that I'm not going to go into because it'll get too clinical. But I am going to share a little bit about how we use EMDR with our clients. And the important part, what makes it unique, is that it uses bilateral stimulation, eye movements, tapping, or tones. And I'm going to talk about that in a little bit more depth in a minute. The first phase with our clients is, like I mentioned, psychoeducation on trauma. What it even is, how is it showing up in their body? Helping people who maybe have never even been in therapy, connecting with their body on that level. So the first couple sessions is history taking, figuring out where the trauma is, what it feels like in their body, before we even begin to address the event and the memory. We make sure that they have what we call, or what is called in EMDR, resourcing tools. For lack of an easier term is coping tools. So we spend a couple sessions making sure and working with and teaching our clients how to ground themselves in their body, because we're going to be working with them in a very activating way. We're going to be working with them on a traumatic memory. And so we need to make sure and ensure that they are able to tolerate how this feels in their body and contain it between sessions. We want them to be practicing it before we even get into the processing. So an example, in fact, with all therapy, I'm doing deep breathing exercises. So deep breathing, we know, is a very regulatory way of reducing activation in your body. A dysregulated nervous system needs breath. Breathing slows down heart rate. It slows, it reduces muscle tension. It clears the mind so that the mind and body can actually, for lack of a better word, come online. When we're dysregulated in our body, when we're experiencing trauma or heightened anxiety or panic, we are not regulated, we are not grounded, we are not in the present moment. So this is a very empowering tool to teach clients. I use it myself. Hopefully you all will, even if on your own, maybe you want to do a little research into some of these grounding resources because they're really impactful. So we do deep breathing. We also make sure that they have a grounding tool called the container method, where I have them imagine a container. I walk them through sorting through their mind and their body and taking anything that's causing disturbance to put in the container. It's much more detailed than that, but for in the interest of time, I'm not going to go into all of them, but I just wanted to give you some examples. And this is just to contain it. We're not avoiding it. We're just putting it away for later between sessions. So after we know that they have the skills necessary to contain anything that may come up between sessions, we work with them to identify the memory, which in this case, we both already know. We've been brought together because of a traumatic incident. So we have the memory, and then we'll ask them what is the worst part of that memory. We pair that worst part of the memory with a negative cognition that they have about themselves. This is where the cognitive part comes in. So we ask something like, if you were to think about the worst part of that memory, say the tires are screeching and the windshield breaking, and how you feel in your body right now on a scale of 1 to 10, 10 being the worst, they'll usually rate it about a 7 to a 10. What is the negative thought that you have about yourself? And what they usually will say is something like, I can't protect myself, I'm vulnerable, I'm not in control, I'm powerless. It's a very black and white, all or nothing thought. And now that thought is what shapes their entire lens for the world. And what we want to do is we want to get them to a more balanced thought, and they do too. So we help them come up with a positive cognition, which is usually the opposite. So they may say, I have the ability to cope with things as they come my way. And then we do the processing on the memory. I'm going to show you briefly what this looks like. So traditionally in EMDR, we used eye movements. I'm going to kind of move back so you can see. And we would have the client follow our hands left to right, or a light source left to right. We control the speed because if you're going faster, it goes for deeper processing. Because we are 100% remote, which is great for our clients, especially if there's an avoidance piece to their trauma, we don't have to worry about that. They can show up right in their home and online. But because it's online, I do not use this for several reasons. One is we could freeze, and then that interrupts the processing, and they could be in the middle of a very activated part of their memory. And also with our clients, having a lot of them have headaches and migraines, this can aggravate it. So I never use that, to be quite honest. I use tapping. It's called a butterfly hug or tapping. You cross your arms. I'm doing this with my clients. Not only is this grounding already because they are touching themselves, they're connected to their body, we're together on screen. And then when I have them bring up the memory, the worst part of the memory, I will tell them to start processing with me. We do this in about 15 to 30 taps. Any longer than that, and they may end up actually opening up neural networks that take them to other memories outside of this trauma, because we are here for a limited time, specifically working on the accident or whatever the trauma was that brought them through the personal injury. We put guardrails on, invisible guardrails. So we do a specific type of tapping for a certain amount of time to keep them in that specific memory. So we tap for about 15 to 30. And there's not a lot of talking going on. I'm just asking them to notice what they're experiencing in their mind and their body. And their mind is doing the healing. It's really fascinating. So their mind is like a train, and it takes off from the station. After about 15 to 30 taps, I'm going to pause them and say, what are you noticing now? That's when they're going to start giving me any insight in their body or what they saw or what they're experiencing during the memory. Now this can go on, this usually, that's a whole session. It can be a whole session. Our goal is to get that level of about 7 to 10 that they rated the disturbance in their body with that memory. By the end of processing, we're looking for a much lower number. If they get down to a 1 or a 2 in that session, they're going to be having huge benefit afterwards. Oftentimes we may only get down to maybe a 5, maybe a 4. We're going to come back in the next session. We're going to start over again with that memory until it's lower. What we do tell them is between sessions, they may have new insight, because as we're doing this, tapping, this bilateral stimulation that's activating their nervous system and lighting up their neural networks, they're going to discover things that they hadn't thought about before. So it's very heavy. There's a lot involved in this. As I mentioned, I'm certified in it. Training, the basic training, I think, is 45 hours. It goes on beyond that. I know this is kind of a speed course in what EMDR is, and I just wanted to briefly be able to explain how we use it. It is not hypnosis. We are not erasing memories. All we are doing is helping people get unstuck and helping their brain. Well, their brain is actually going to do the work in filing this memory where it belongs, which is in the past, so that they can say, oh yes, this happened, and speak on it, but not feel like they're reliving it in the current present situation. Okay, so I just wanted to share some cases that I thought were pretty interesting. In 2015, Bocha did a meta-analysis of people who had been in motor vehicle accidents, had PTSD, and using EMDR with them. And what they found is that there was a significant reduction in flashbacks, a reduction in intrusive memories and avoidance behaviors. What was really cool is they used a functional MRI while they were doing EMDR, before, during EMDR, and after. And while they were participating in EMDR, they were able to see that it activates the anterior cingulate cortex, the fear center, the place that regulates fear in the brain. So EMDR is lighting up neural networks and allowing the body to process out that trauma. So, I wanted to show this since it's so specific to the population that we work with. EMDR shows both clinical and biological effectiveness, which is just so powerful. It's considered a bottom-up and a top-down therapy. Whereas I mentioned before, most of therapy is either talk therapy, we're talking through it, or we're just looking about how we think about things. This is really working with our whole body. And for people who have injuries on top of it, we know that stress and chronic stress, which is basically trauma, is going to get in the way of them healing from their physical injuries as well. So another one here is, this one was more in 2021, shared a case where a pedestrian was 57, he was crossing the street and suffered from a mild traumatic brain injury. Within 9 sessions, the PTSD symptoms reduced, and they also reported a improvement in the post-concussive symptoms. So after 18 months, they did a follow-up, and they did another follow-up 4 years later, and the improvements have sustained. So there's research out there showing how effective and how quickly we can treat trauma as well. EMDR is able to get into the body and in the memory and work with trauma at a much quicker pace than some of these other treatment modalities that are still evidence-based. As you see here, 9 sessions. The one before was 6 sessions. I'm going to share a personal anecdote, a clinical anecdote. So I was working with a gentleman who had such extreme anxiety after their accident that they became more and more isolated to the point where they were not leaving their house, and basically was developing into I can't say the word right now. They didn't want to leave their house. It was a panic disorder. So while they were leaving the house, they were experiencing panic attacks daily, and then basically decided to stop leaving their house. By the time he got to me, it was 8 months post-accident with no mental health treatment, and he was no longer attending any treatment for his injury. So it's not that he didn't want to be compliant. He couldn't be compliant. He wasn't getting help, that's for sure. Because we were online, we were able to work together, lots of resourcing to get him grounded, to show that he had specific tools that he could use to reduce the symptoms, to build the trust that we could work in a safe environment where he has 1 foot in the present right here with me and only 1 foot in the memory. We don't want them all the way in the memory. We want them to be able to vacillate between that past and being in the present. So we worked together to do EMDR, doing EMDR together, worked on the memory, and we definitely did not clear that memory in the first session because this was pretty intense, having the fact that it had been 8 months since he'd received any sort of treatment. But within the first session, I mean, this surprised me. He comes back to the next session and, we had only gotten, he was rating it up, his disturbance at a 10. And when we finished that session, he was rating the level of disturbance at a 6. So it had gone down, but it was definitely nowhere near resolved or cleared, as we call it, cleared out memory. The next session, he came back and he presented as more regulated in session. Before each session, he would have to do deep breathing just to turn the camera on. he said he was able to open the door and go out and pick up his mail for the first time in 3 months. So that's a huge win on one session. So I'm a firm believer in its ability to help. I don't have all the research and the science and the background into why. I just know that it does. I'm going to move forward here. I'm going to share that one. And just, you know, as mentioned, this is EMDR is a research-based therapy modality that the meta-analysis shows is equal to CBT for PTSD, if not more effective at times. Studies show reduced intrusive memories, faster recovery. For our purposes, we don't have a lot of time when we're working with our clients for financial purposes, litigation purposes. We have a specific amount of time often to work with our clients, and we want the most bang for our buck to help them as quickly as possible. There is nothing more rewarding to me than to be able to see somebody walk away after one session with coping tools to help themselves feel more in control than they were when they came in. And that's just one session. After that, having several sessions to be able to see that life, that they can gain traction, that they don't have to be stuck, that there is hope. This is why I do what I do. One of the other things I'm not sure if I touched on, but this is also really beneficial to our clients, is that we know that there's oftentimes lasting pain. Sometimes they're going to have chronic pain. And I did say, I truly believe that physical healing can be impacted by our mental health as well. So if we're healing their mental health, they're going to be able to heal better physically, but also they're going to be more compliant with their medical treatment. Maybe they'll go, maybe they can go and be able to go and participate. So we're coming to the end. I know I did a speed, dive through what EMDR is. I'm sure there are some questions that people might have. I do have some links that I'm going to drop in the chat box if anybody wants to look at the studies more in depth. And I also have a link that I'm going to put in about what is EMDR therapy, should you want to go to the website and just do a little bit more research for yourself, for family members, for your clients. It's so helpful for so many people. The biggest takeaway here is keeping an eye out for trauma symptoms of trauma. As mentioned, avoidance, panic, irritability, frustration, and working together with psych centers, medical providers, attorneys. Our clients are going to reap the benefits of healing faster with this umbrella services of care. So at this point, I'm going to go ahead and turn it over to Jen to let me know if there's any questions.
I had some follow-up questions just based on your presentation. So when they're referred into you, at what stage are you finding that they're coming in? Is it really close to the beginning? Is it maybe after a period of time that they've been getting some treatment? What have you been noticing, and what do you recommend if it's not in the cadence that you would think it was most beneficial?
Okay, so the majority of my clients are coming in months after the event, months. The earliest that I've seen people has maybe been 3 months, which that's the best case scenario, being that it's the earliest. But 6 months and beyond becomes much more complex. They've been living in this state for so long that that's their normal state. So to unravel that for them, I mean, they've become regulated to the dysregulation, if that makes sense. The sooner that we can get in and start working with clients and showing them benefit and tools and the ways to heal, the better for everyone.
So when they get sent in, what is the process that the team does to get them going? Because I know you said that you can't just jump into this treatment. There's a couple of stages to kind of educate and kind of build some rapport. Maybe talk through those early steps.
So the early steps, there are more constraints in this type of work from a therapy standpoint when we don't know how many sessions we have. 5 sessions is not a lot of time. Regardless of using EMDR, though, as I mentioned, I'm always using those resourcing or grounding tools anyways. I've never met a client who didn't come in that didn't need one. and the psychoeducation piece. So even if they leave after 5 sessions and that's what they got out of it, they've got something better than they had. And I always leave them with resources on how to continue in treatment. I would say the majority of them need it longer than 5 sessions. Also, most of my clients have never participated in therapy so there's no groundwork. They don't have a lot of coping tools to begin with. So I'm kind of not really answering your question, but what that looks like is I have a team of clinicians that when I'm making my referrals to them as well as to myself, if any of them are able to identify in the first session, and it's pretty clear with some people that they could benefit from more, and that EMDR would be the modality treatment that we would suggest, then we'll reach out to attorneys to see if we might be able to get additional sessions up front so we can just get started. I'll also have them transition them to myself or my other certified clinicians in EMDR. So we work really well together as a team. Building rapport, I mean, the good thing about online telehealth is people tend to dive in real quick, and they know we only have a certain amount of time. They know why they've been referred to us, so we can get right in pretty quickly. It doesn't take as much time as some traditional talk therapy where you don't even know where you're going. Sometimes you're not sure why you're there. You're just going to come as long as you want. We're here for a specific reason, so that helps. And for some clients, I can't start EMDR because, as I mentioned, it is very, very important that they have the resources to be able to take care of themselves between sessions. So I'm not going to go process a trauma and dysregulate them and then send them out in the world. That's dangerous. So there's just a lot of clinical knowledge that goes into assessing who it's best for, how to use it. There's even an abbreviated form of EMDR that I didn't talk about. I'm not going to, but we use that a lot here too, and it's called EMD. It's a shorter form where we can maybe not have to go through the whole 8-phase protocol.
How often are you finding that someone who's coming in for treatment has prior treatment, like they've been in multiple accidents, or like, and how do you, like if it was a big T and then they're processing, like, I know you mentioned those guardrails, like are there times where you kind of have to go back to, and then you make note of it, or do you bring in another outside person for referring out to address that side?
So the first question you asked is, what am I finding as far as have they been in treatment before, was one question. And the other question was, how often am I seeing that they've been in multiple accidents? Those were your first two questions, right?
Right. So basically, we see a lot of, especially attorneys, they see a lot of people who've maybe gone through this more than once. And maybe the first one was a big T and they haven't been, because a lot of the patients haven't been seen at all. And so then they get hit again, and then this just exacerbates just like the pre-existing conditions of pain.
Right.
How often are you finding that, and how do you like work that in and also keep it, I don't know, separate, or how do you approach that?
That's an interesting question. So because I see a limited amount, because I'm more overseeing things at this point, it would be better for me to ask my clinicians who are seeing more of the people. But we know, you've heard this, that after you've been through one concussion, you're more susceptible to more, which I don't know why. You just are. It's like nature is coming to find you. They don't really know why, but I've heard that multiple times. So yes, it obviously does happen, but it's not the majority, thankfully. That would be really hard if it was just accident on accident on accident. Now, most of them haven't really, like you said, had treatment. So I don't have anywhere to start with there, or if they haven't necessarily they haven't participated in EMDR. So at least they're getting a different lens. And even if we were all practicing from the same modality, you're still going to get a different lens with a different clinician, just different styles. So they're going to get something out of it. Now, if they've been in multiple accidents, they're still, what I found is they're going to be in that first accident, the most recent one. That's what they're there for. And they're dysregulated from, the whole thing is going to be some core belief about safety, period. So the events themselves don't really matter so much as getting to the core belief of what is making everything get stuck and how they're functioning in the world. So that's how I treat it. The guardrails that I'm talking about, we know how to do a certain number of tapping and to keep it so that they stay in the memories that we're trying to work on. Traditionally, EMDR is more used for people who have a history of trauma, or let's say they're coming in and they're like, I'm here because I've been in an accident, and we have all the time in the world to work with them. What we want to do is find out that negative belief I was talking about and tell me about a time in the past that you felt like that. We float back. We'll float back. They might be like, oh, let's say we're in our, we're 45. I remember a time in my 30s. Can you tell me about an earlier time? 20s, teenager, childhood. We go as far back as we can, and that's actually the memory we start with. But we don't do that in this work. We stick with this guardrail. So that's how we do it. Hopefully that answered it.
Yeah, for sure. And I was and I'll open it, but I'm going to hijack you for just a minute, because I was just really surprised when you mentioned how EMDR helps the concussion symptoms, and that's pretty amazing, since everyone who's coming through our doors pretty much have some type of concussive symptoms, and that it can help both. And is it just where it's tapping into your brain that it's activating and healing?
So it's chicken and egg, right? So concussion or not, if you're just an anxious person or have PTSD over something, that the part of your brain that's lit up all the time now it's not logic. It's not even in the present moment. So it's going to interfere with logic, reasoning, being grounded, coming from a place where you can rationally make decisions. It affects that center. So it's affecting concentration and focus. So let's say you didn't even have a concussion and we address those things, you're going to find that maybe you have less brain fog. You're more able to complete tasks and concentrate on what you're doing, not as distractible. So if we have somebody with a concussion and we have this too, reducing something is going to help overall. So it's not resolving the concussion, but it's definitely going to help with clarity, mental clarity. And then maybe let them participate in what's helping with the concussive parts, like the cognitive therapy that's specifically for like speech therapy and whatnot.
Okay, that makes sense. I'm not sure if people can actually raise their hand in this setting today, but if you have a question, if you can put it in the chat box, and I'll just pause.
I'm gonna drop this link too, just in case if anybody wants to learn more about it. That's a really great resource. Oh, my phone's turned off. I also had a podcast too, in case anybody wanted to listen to it, but I got my phone turned off, so I wouldn't be distracted.
Well, we can send it out with the recording too, which would be
okay. I'll do that.
Helpful.
And,
that's a good idea.
If anybody wanted just, if anybody's interested in the links for the research, I'll just put that in there as well, and people can click on it if they want to.
Okay.
Do a deep dive into the research too. Some people are really interested in that. I'm not.
What is Boccia?
Boccia. He's an Italian researcher. He's just, that's the article.
Okay. Is he kind of the guru? Did he help?
No, the guru is Francine Shapiro. She developed it. So she wrote the book, she developed the program. Don't ask me how she figured it out, because I still don't even understand how this actually works. I just know that it does. The research articles, if you want to go down that, I would more in how does the therapy work? What does it do? Let me practice it. Let me see the results. And it's really impactful how quickly it can start to dislodge some of the trauma responses.
It sounds like you were kind of surprised by that because of your experience with other types, that you're like, this happened that quickly?
Yes, not only just it happening that quickly, but I mean, listen to how I'm even describing it. What is this woo-woo you're talking about? We're going to sit here and tap and reprocess memory. It wasn't as tangible as cognitive behavioral therapy for me. Let's look at what you're thinking, how it's making you feel. Is it accurate? Is it grounded in reality? EMDR, we're working with the client's brain and body. It's amazing.
That is cool. So I don't have any other questions posted in here, so I still have some questions for you because we have time.
Okay.
Because the whole big T, little t, I think is just so critical, because this reminds me of the whole mild TBI and how it's a misnomer, and how people think mild means minor, but that, what you were describing is these little T's are a cumulative thing that's impacting them every day that wasn't their fault, and they have to deal with it. And then you mentioned that when they come into you, it's a new reality. So they're not the same version of themselves before the accident. They have this new persona that is their new. And I was wondering if the idea of having chronic pain is something that's considered a mild trauma, like a small T. Because
for sure,
again, people aren't used to having issues. And then there's that point where you're like, this is my new reality. I'm always going to have my neck stiff in the morning, and they just have to do all these extra things, maybe take medications they didn't take. And they're like, I'm not a healthy person anymore. And so their thought of who they are in the world is impacted. So like, is that something that is significant to document so that the attorneys can say, hey, this is a small T. This wasn't the event that caused this thing, but they're now going to live with chronic pain. And that's a small T.
Absolutely. And chronic pain in general is noted in every session. Part of my work with clients and all my clinicians is asking about their medical treatments, because it's everything that they're submerged in, and it's so disruptive to them, their pain and the appointments and trying to attend them all, make them all. It impacts their relationships, their jobs, if they've even been able to keep their jobs. I mean, it's so far reaching. So even though we're doing EMDR on just the traumatic memory, all of these other things are also going into play in our work together and documentation. And what you said is a huge part of therapy too. And that's why I don't do EMDR is not what I do with every single client. It depends on what they're experiencing. And I have some people that come in, they're not necessarily experiencing like the flashbacks and I can't drive anymore, but it's that fear of what is my life even going to be anymore? It's completely different. My hopes and dreams and what I thought about, and I do work with people like that. And that is definitely documented because their entire life has changed. I have a client that I work with now outside of PI that came through PI, their time ended. They're not well, they're not better. It's 3 years post-accident and we're still working together, and it's all accident related. A 34-year-old woman who was working in high-tech, fast-paced tech job, over $80,000 a year, is working on getting disability, working part-time in a gym because she will never be able to keep up and maintain cognitively. Hers was all cognitive. Right. So yeah, good question. It is tragic.
Yeah, it's got to be hard on your side to separate your feelings of like, that sucks for you, and just to support them in that. John asked, why has the medical community been slow to adopt EMDR? Like, why did it take so long if it started in the 80s and there's got all this great evidence?
Right. Well, so all I can do is give you my theory, right? Because I haven't done research on that, but I do note that. And when you're like, oh, it's relatively new, because I feel like it's new as well, but it's not, which surprises me. And I was in school and it wasn't even mentioned because, like I said, we're old heads in any industry. So would you say the medical community, therapists, we come from a strong background of Freud and psychodynamic. And how long did it take for us to get away from that and get into more CBT, DBT, that type of work was what was relevant. That didn't mean other things didn't exist, but that's what we were doing. Now, I can't really say why it took so long, but I can say the trends have definitely shifted to polyvagal theory, which is a body-based theory. It's that vagus nerve that we know runs from the brainstem all the way through these major organs through our body. EMDR, somatic experiencing, that's body-based. So we just ebb and flow where the research comes and goes. And, clinicians were always wanting to stay abreast of cutting edge research, but research in general, I think it still takes a while. Also, it was really dominated, if that's the right word, or localized in the VA with its use with veterans. And so, we're talking about the VA, that takes a long time too. So they were doing their stuff, and then they started, it started getting out into the mainstream therapy world, and word of mouth is what's making it take off. And also it takes a lot of training. It's so much more training. It's very, very, very involved, more than other modalities. So that's part of it too.
For sure. And I guess because they broke out of the VA and they experimented with, PTSD and other circumstances, probably with childbirth issues and just a whole bunch of grieving issues could be utilized. But is there a time where EMDR is really not appropriate, where you would definitely stay away from it? Or wouldn't work, it was not effective? That's also a question from John.
Yeah, I think it's more, you know, again, it's individualized. There's no like clear cut, absolutely no. It's based on the person. Can the person, if they're dissociated all the time, I don't know if anybody knows what dissociation is, but it basically means you're like not in your body. You're kind of wandering through life, you're just not in your body. It's like you're observing from outside. So you are not present. You are not grounded. You are not in your body. We're not doing EMDR. And some people are highly dissociative, like dissociative identity disorder. I wouldn't work with EMDR with people that are in that realm. There are some people that their whole life eat, sleep, breathe EMDR. Maybe they do. But I'm specific about, you know, it's always work within your wheelhouse, right? So there's not too many, but you said something really interesting about birth trauma, and EMDR is used for that, postnatal depression, grief and loss. I mean, anything that's stuck, anything that you're stuck with is what EMDR can help you with.
Amazing. Well, thank you. We're at the top of the hour. That was a great presentation. I learned a lot. I can only imagine how much everybody else learned. I want to do one last plug here, shameless plug for our conference that's coming up. Please come out. We're going to have excellent speakers. Dr. Hertz is going to be one of our speakers. Just a great lineup of both attorneys that are using neurotrauma care in their cases and getting amazing outcomes, and at the end of the day, better recovery for their clients. And then on the medical side, I think anytime you crisscross conversations between medical and legal, and we're working all together as a team, it helps just better continuity, communication, and just knowledge that otherwise we don't know. So this will be our first one. So please mark your calendar, get registered. And with that, we are going to close out. And thank you again, Kristen, for your time. This is amazing. We're going to have you on again because I have more questions. So we're going to have to do part 2.
Give me a call. Have a great weekend, everyone. Thank you.
All right. Thanks, everyone.
Bye-bye.
Bye.